Prostate cancer is one of the most common cancers in men, and one of the most misunderstood. Its defining feature is a paradox. Many prostate cancers grow so slowly that they'll never cause harm in a man's lifetime, while a minority are genuinely aggressive. The whole challenge of this disease is telling those two apart, and not overtreating the harmless kind. Let's start with that paradox. The prostate is a small gland that sits below the bladder and makes part of the fluid in semen. A great many prostate cancers are what doctors call indolent. They grow so slowly that a man is far more likely to die with the cancer, of something else entirely, than to die from it. But a real minority are aggressive. They grow quickly and can spread, particularly to the bones. So the central problem in prostate cancer isn't finding it, it's figuring out which kind you're dealing with, because treating a harmless cancer aggressively can cause more harm than the cancer ever would. The main tool for detection is a simple blood test measuring PSA, prostate-specific antigen, a protein the gland makes. A raised PSA level can be a sign of cancer. But, and this is important, it can also just mean the prostate is enlarged with age, or inflamed, so PSA is an imperfect screen that has led to a lot of unnecessary worry and treatment over the years. When there's real concern, the next steps are an MRI scan and a biopsy, where small tissue samples are examined under the microscope. A pathologist scores how abnormal and disorganized the cells look. That score is the best early read on whether this cancer is the lazy kind or the dangerous kind. Here's where prostate cancer teaches a lesson the rest of oncology is still learning. For low-risk disease, the best option is often to do no immediate treatment at all, an approach called active surveillance. That doesn't mean ignoring it. It means carefully monitoring the cancer with regular PSA tests, scans, and sometimes repeat biopsies, and stepping in with treatment only if it actually starts to progress. Why hold back? Because the main treatments, surgery and radiation, carry real, life-altering side effects, including urinary incontinence and erectile dysfunction. For a cancer that may never threaten the man's life, active surveillance spares him those harms. Choosing to watch, on purpose, is genuinely the right medicine here. For the cancers that do need treatment, the options track the toolkit we built earlier. If the cancer is localized but aggressive, the main choices are surgery to remove the prostate, increasingly done with robotic assistance, or radiation therapy, and the two give broadly similar cure rates for many men. And when prostate cancer has spread beyond the gland, the backbone of treatment is hormone therapy. This is one of oncology's oldest targeted ideas. Prostate cancer runs on testosterone, so drugs that shut off testosterone can starve the cancer and hold it back, often for years. Newer hormonal drugs and chemotherapy extend that control further when it's needed. So the big takeaway from prostate cancer is one of the most important ideas in all of oncology: more treatment is not always better treatment. The entire strategy is to match the intensity of the treatment to the actual risk of the cancer, to treat the aggressive ones hard and early, and to leave the harmless ones alone under careful watch. It's a discipline driven by evidence rather than by fear, and it spares enormous numbers of men from side effects they never needed. If you're a man weighing PSA testing or a diagnosis, that risk conversation is exactly what to have with your doctor. This is educational, not medical advice.